Without blood, well, we're dead. That makes the way that blood moves in our body very important. Blood vessel disease and the problems it can cause tonight on Call with the Prairie Doc. Good evening and welcome to On Call with the Prairie Doc. Diagnosis and treatment for vascular disease has come a long, long way. And as with most health concerns, early detection is important to positive outcomes. First, let's take a look at this week's Prairie Doc quiz question. It's a reverse multiple choice this week. Pick the least important key to longevity and preventing vascular disease. The least important: number 1, eating a healthy, balanced, low-calorie diet. 2, exercising and avoidance of sitting for long periods of time. 3, controlling diabetes. 4, keeping cholesterol in check. And 5, avoiding smoking. Viewers who call in the correct answer will be entered into a drawing to win a signed copy of our book, The Picture of Health. Each of my essays, originally written for the show, comes with a wonderful accompanying photograph by Dr. Judith Peterson. We will announce the winner, the answer, at the end of the show. Remember, you only have 10 minutes to get your answer in. But we answer your questions about vascular disease all evening as they are called in or sent to us via Facebook or email. Call in questions to 1-888-376-6225 or send us an email to the address on the screen. Joining us tonight are Dr. Mike Bacharach of North Central Heart, a division of Avera Heart Hospital, and Dr. Dustin Weiss, also with North Central Heart. Welcome, gentlemen.
Thank you.
So we have a classical surgeon and a classical internist, and you're partners in crime because actually you've kind of turned surgeon, haven't you, Mike?
Well, yes, and as things have evolved with the development of endovascular techniques, which is the ability to fix the arteries from the inside out rather than to have to do open operations, that's changed things. And so the two specialties have really come together, and in many ways we do things in concert. We work together, we often do cases together, and similar type techniques.
The word endovascular means inside blood vessels, right? Dustin, so you're the surgeon person. So you do a lot of what he does, but you also do something else.
Yeah, so I'll do both the open operations, for instance, bypass surgeries or endarterectomies for blockages, but then also, now that more and more of the vascular disease can be treated endovascular, a big part of vascular surgery training is endovascular, or treating from the inside the blood vessels, similar to a coronary stent where we'll get across the blockage and treat with either a stent or now we have medicated balloons that we can often use. Medicated balloons,
so that they give off a medicine, not just the stent, but the balloons have medicine in them.
Yeah, so there's balloons that we have now that have like chemotherapy type medications on them, so you can just dilate the blood vessel, and these medications prevent that blood vessel, because whenever you injure a blood vessel, it wants to respond by kind of scarring down inflammation, and these decrease that inflammation, and they have shown promising results, and then you don't leave a stent and a foreign object in the blood vessel.
Oh, so they're doing without leaving the stents now. Not always, but many times.
Yeah, not always, yes. So not always. It depends on how the lesion or how the blockage responds to the dilation. But yes,
that's an advancement.
Yes, I mean blockages that we used to have to treat with stents 100% of the time, now we can treat often with just a balloon that has medicine on it.
Wow, I mean that's a new. How long has that been going on?
Well, we've been using them now for at least a couple years when they've been kind of been more frequent, and even before that we were starting using them.
So this is very interesting. So now the future endovascular people are not cardiologists coming up from internal medicine ranks, but they're surgeons. Isn't that right?
Well, it depends a little bit. There's still interventional cardiologists that do predominantly coronary work, so they're the ones who fix heart arteries. Cardiologists have evolved now so that now we can do some valve and structural heart things through a catheter, so that you don't have to do open operations. So it's changed that paradigm of that used to have to send the patient to a surgeon or you had to have your chest opened. Now we can sometimes treat that without. From a vascular standpoint, vascular surgeons, contemporarily trained vascular surgeons like Dr. Weiss, clearly have taken the preeminent role in treating endovascular therapies for arterial disease of the legs, aneurysmal disease, that sort of thing.
So it's interesting. Are they doing coronary artery balloon dilation with chemo and not stents, or are they using stents most of the time?
No, most of the coronary interventions still use stents. Most of the coronary interventions still use stents, and they generally use stents that have a drug coating on them to help prevent that restenosis. In the small arteries, it's important to have a scaffold effect to help open that artery to prevent elastic recoil. In the peripheral area, where both Dr. Weiss and I work, they're a little bit more forgiving. The vessels are larger, so even if they recoil a little bit, it doesn't cause obstruction or doesn't cause them to completely close off.
But it would be better if we didn't have a foreign body in there, if that's possible.
Yes.
That's really interesting to me. So your world is mostly arteries that feed the legs, the kidneys, the brain, the arms. But most of the coronary disease is done by the cardiologist.
That's correct.
Correct. Yes.
Yeah.
So what is the most common site for your activity? Is it the aorta itself, or is it legs? My experience was sending patients. I don't know how many patients I sent to you over the years, but a ton, Mike. I think about a lot of them were legs.
So, I think you're right. So from my perspective, I think that certainly the most common presentation is blockage in the arteries of the legs that results in people having leg discomfort when they walk. And we have the
Claudication.
Claudication, that's right. And so what happens is they're going to the grocery store, they can't walk across the parking lot, they have to stop, they're on a regular exercise program, they can't participate, that sort of thing. And it becomes lifestyle limiting. The vast majority do not have threatened legs. Their limbs aren't threatened, but the vast majority just can't do their exercise. Now, the implications of that are that if you can't exercise, it tends to reduce your cardiovascular survival or increase your risk of premature death. So I think one of the big things about technology is that now that we can fix many of those arteries without an operation. It's allowed people to have a procedure that's minimally invasive and then gets them walking. And if we can couple that with risk factor modification, we can get them to survive longer and, more importantly, have a better quality of life.
So exercise is pretty darn important, isn't it? If you can't walk, you can't exercise.
Exactly. Yeah, but I think interventions are important, but also the risk factor changes are just as important as interventions. So if you don't have an intervention and you continue to smoke, you likely will progress to losing a limb. Whereas if you quit smoking with or without an intervention, the risk of you actually having an amputation is low.
So earlier we talked before the camera came on about the changes from people who have a vascular fix on their legs and continue to smoke versus someone who had the same vascular repair and quit smoking. What are those numbers?
Well, the chances of any intervention you do staying open if they continue to smoke is much lower. But in general, if you take all patients with claudication or pain when they're walking, and there's two important divisions of arterial disease, peripheral disease. One is claudicants, and those are the people like Dr. Bacharach talked about that at rest they're getting enough blood flow to their legs, and when they walk they need more oxygen and they can't get that, so that's why they get that pain. Now then, the second group are people with what we call critical limb ischemia, and those are patients that even at rest they're not getting enough blood flow, and so those are the patients that are very high risk of losing their limbs. So they'll have they'll wake up at night with pain in their foot, and they can hang their foot over the bed and they'll get better just because gravity will help pull the blood flow down. Now if you take patients that have pain when walking, so the claudicants, if they continue to smoke, intervention or not, their risk of going to critical limb ischemia in some studies over 6 years has gone up as high as 80%. Now, if you take that same group of people, intervention or not, and you have them quit smoking, only about 8% of those patients will develop critical ischemia. And that's important to prevent that, because once you get critical ischemia, you know, there's been some studies published that if you present with rest pain or an ulcer on your foot, you know, the mortality of that is about 20% at a year, and the limb loss is up to 40%. And so if you look at that, at a year, only about 40 of those people are alive with both their lower extremities. So it's very important to prevent people from getting to that critical limb ischemia.
Well, a lot of it is related to diabetes too, isn't it? I mean, vascular disease kind of follows diabetes. Would you agree with that?
Certainly diabetes is one of the contributing factors. The pattern of disease with diabetes is a little bit different. It's often in the lower portion of the leg from the knee down, and it is more difficult to treat. It's more difficult to treat endovascularly, and it's more difficult to treat surgically. So that's why it's important you know, to manage and optimally manage diabetes if you have it, to keep your hemoglobin A1C reduced to its lower level, that you monitor your blood glucose, that you exercise, those sorts of things. So optimal management really is important with diabetes.
Right.
You're right.
I was thinking about venous disease earlier before this show, thinking about, you know, arterial disease and venous disease. Those are the blood vessels, and that's vascular system. You know, that goes out and comes back. It's the cycle of life. You've got to have the circle to work for the arteries to bring the blood out and then bring it back. A lot is, there's a lot of problems people have with venous disease. Do you deal a lot with those? Yeah,
as vascular doctors, we take care of, you know, arterial, which is when your heart pumps the blood. That's the high pressure that carries the blood to your extremities or to your organs, and the veins, which carry it back to the heart.
That's a low pressure system.
Yeah, which is low pressure. So we take care of that, and then we also take care of, which is a difficult thing to take care of because there's not a lot of interventions for it, is lymphatics, which is when the blood flow goes from the artery to the vein. Some of that fluid leaks into the tissues there, and then that's carried back to the heart by lymphatics. So we take care of all three of those systems.
As an internist, I dealt time and time again with swollen legs. And they say that, of course, it's the systems of low protein from liver disease, low protein from leaky kidneys. It's venous disease from not bringing it back, and then it's heart pump weakness. So it's those are the reasons why people have swelling in their legs. But the majority is probably venous disease, wouldn't you say?
It's difficult to tell. I think that majority of patients with bilateral equal lower extremity edema is common, that it's a systemic problem, like either heart disease, sleep apnea that's not treated, that will lead to that. Now, if they have large varicose veins, then it's obviously more likely to be secondary venous disease, and those are nice, very good patients to take care of because they have significant relief of their symptoms. We have good treatments for patients with incompetent veins, meaning that the veins are supposed to carry back to the heart, but gravity wants it to go down towards the feet.
And so the valves are gone.
So if those valves aren't working, then you get a long column of blood, which is high pressure, and then that makes their veins come out, and they get varicosities, they get edema, they can get ulcers even from the venous disease. And those are patients, when you treat that, they really do have a significant improvement in their quality of life.
By removing the bad veins? And using a lot of support.
Yes, yes. So a lot of it is exactly the first treatment on everybody is the compression stockings, and those help a lot to help. They push the blood flow, the swelling into the deeper tissues where we want them to be. And if that doesn't work, if their veins aren't working, then we can use a catheter to either use a laser or radio frequency to scar the vein down.
So there's a lot about venous disease. It's really important. We can talk about that, and we've got questions that we need to answer. Medical outcomes are always better the earlier they're diagnosed. Waiting for a problem to strike isn't the best time to start treatment.
I got done running, and I came home, and I had what they call it an aortic dissection. It was right outside the aorta. I called 911. The ambulance came and got me. We went to hospital here in Brookings, and then they asked me where I wanted to go, so I went to Sanford in Sioux Falls, and that's when they found it. I thought I was originally having a stroke. My dad died of a stroke when he was 60, and it kind of runs in our family. So My leg had gone numb, and my left hand had gone numb, so I kind of was worried about a stroke. He started right at the aortic valve, and then he comes up and over, and he laid it at a certain angle so Dr. Kelly could put his stents in and finish this. So it was an orchestrated plan once they did the first one, and saved my life. 3 years ago, I ran my one and only half marathon in Sioux Falls. I ran it in 1 hour and 50 minutes. I was pretty proud of that. But they also say if I wouldn't have been in the shape I was in, the consequences may have been different. My heart was getting really weak. And just from being up at cardiac rehab and moving and doing everything they suggest you do, and it's kind of at your own pace, but just having the camaraderie of other people that have gone through similar things, it helps. I wish I would have went to the doctor more. When I was laying in the hospital after my emergency surgery, they were asking me who my doctors were, those kind of questions, and I said, you're looking at a guy that's 55 years old that doesn't go to the doctor. And we should all go to the doctor. Just be proactive instead of reactive. I think it might be a lot better off for him.
This is your program, and your questions are key to the direction of our discussion. Call in your questions to 1-888-376-6225 or send us an email to ask@prairiedoc.org. We would love your questions. That makes us have a direction, and so please give us your calls. Well, here's an interesting story of a man with multiple aortic aneurysms, or complex aortic aneurysms.
Well, yeah, it sounds like he had a type 1 aortic dissection, which is a tear of the inner lining. And you have to remember that the aorta is made up of multiple layers. And when the inner layer pulls away from the outer layer, that's called a dissection. Generally, there are some structural things and some genetic aspects, but the vast majority of those are related to high blood pressure, and where blood pressure is not particularly well controlled. Some cases, hardening of the arteries, atherosclerosis, tobacco use, those things contribute to weakening or degenerative changes of that big blood vessel called the aorta, and that can result in a tear. So that's a life-threatening event, and certainly kudos to the physicians who looked after him, because that's a high mortality operative procedure, and one that sounds like he did really very well.
Really well. He ran a 1 hour 50-minute half marathon. Let me tell you, I've run a little under that and over that in the past when I was running. So Mike described it as a tear in the wall, and then it dissected in, and I'm sure that pushed into the flow. But there are other kinds of aneurysms where it dissects out. I mean, it blows up like an inner tube, right? Can you describe it? There's different kinds of...
Yeah, I mean, well, there's two different things. A dissection is when you have the walls separate. And you can have those, his must have been ascending aorta, or the part of the aorta between the heart and the carotid artery, or the neck vessels. And those need to be surgically repaired right away. Now, there's also dissections that go down after the blood vessels to the brain, and those we can often treat medically with blood pressure. Now, those dissections aren't aneurysms. So an aneurysm is an enlargement of the artery, up to 1.5 times the normal artery. So a normal aorta is about 2 centimeters. So anything over 3 centimeters is what we defined as an aortic aneurysm. Now, a dissection, you can imagine if you have three layers of the blood vessel and you get the inner layer torn out, that does weaken the wall. So it does increase your risk of having an aneurysm, and we do monitor them for aneurysms later on. But a dissection and aneurysm are different. An aneurysm is a dilation of the blood vessel, and just like if you're sitting there blowing up a balloon, the bigger that dilation gets, the tighter the wall is, and eventually it can pop. And if it's an aortic aneurysm and it pops, then your risk of mortality is very high, and up to about half the patients don't make it to the hospital.
Yeah. So that leaves me with the question about ultrasound of the abdominal aorta, looking for aortic aneurysms, classically, quote unquote. So there's been a traveling circuses that bring in, I'm sorry, I didn't mean to be negative. They ultrasound your carotid, they ultrasound your aorta, they ultrasound your legs, and then they do a bone marrow ultrasound, a bone density ultrasound. They tell you all of this for $150 or whatever it might be. I've often thought that I tell people skip all of it, but get the aortic aneurysm test, and if that's abnormal, then you go to your regular doctor and get one. But will it pick up a dissection?
Probably not. I mean, it could. Probably not one of the screening studies, but generally if you have a dissection, you will have some. The difference between dissection and aneurysm is that generally when you have a dissection, the blood vessel wall tears, and so they'll have pain. Usually they'll present
They'll have
with
a
chest
symptom
pain.
to give you a clue.
Whereas an aneurysm, majority of those are asymptomatic unless they rupture. So, and once they rupture, then there's a very high mortality. So the screening for an aneurysm is very important, because if you can find it when they're asymptomatic and follow it, and then you can fix it once it gets to a size where there is a risk of rupturing, rather than wait until they're symptomatic, which is generally a rupture, which has a very high mortality.
Yeah.
So, just as a comment, I think that Dustin's absolutely right. The screening issues have been controversial because you're right, you would like to identify these aneurysms beforehand because we can fix them and then prevent a rupture from occurring.
Right.
They often are only found by incidental findings. Someone comes in with abdominal pain, they have an x-ray, or they have a gallbladder and they get a CT scan, and then they find it. And so a lot of patients that come both to Dr. Weiss and myself were found incidentally. They don't have they're not aware that they have a problem. The screening recommendations, the formal screening recommendations is you get men who smoked, age 65 or older, get one sort of freebie ultrasound at the time of their first Medicare physical, and that's it. So the Medicare has chosen not to support screening programs, and what do you do with women? We don't know. What do we do with men who haven't smoked? We don't know exactly. So one of the things that's important, and what we tell our patients is, number one, if your family member had an aneurysm, mom, dad, grandpa, that puts you into a risk category, and you should. If you're a smoker, man or woman, you're in a higher risk group. Again, many of these services, and while I'm not a huge proponent of some of these services, many of them are relatively cost effective, and they provide service in some of our more rural or geographically isolated communities where that isn't available. And so to avail yourself to that, you don't need to do it every year. That's probably not helpful. But for a one-time event, and then if they identify a problem, then you go on and go to a larger center or where it might be to get a more formal evaluation.
And I've got some questions, and I really appreciate them. But I would ask this, it also does ultrasound of the carotids in these traveling programs. And I've often poo-pooed those, because once you have an abnormal, it's a more complicated thing to interpret. Comment.
Well, I think that carotid disease, we're treating less and less asymptomatic patients, but if you have a significant stenosis of 80% is what we generally use, then you do have a benefit to treatment. The other thing is they do check an ABI, and they check the pressure on your arm and your leg, and that can detect peripheral artery disease. And I know we talked about claudication or pain when you're walking, but often patients will subconsciously kind of adjust to their peripheral artery disease.
Walk slower.
So they'll be less and less active. So you'll say, are you symptomatic? They'll say no, but they don't even walk to the grocery store or do normal activities. So I think the ABI is useful, because if you do
arterial brachial artery index.
Right. And because if you identify patients, they're at much higher risk of stroke, much higher risk of heart disease, and if you can treat them medically, then you can reduce the risk of mortality from those two.
So you encourage the screen, maybe one time.
Yeah.
Caller from Viborg had open heart surgery. 8 years ago, developed peripheral artery disease and could barely walk. Had surgery on legs to put in a stent on the knee. how long can you go through life with peripheral artery disease and a stent?
Well,
If you don't smoke, obviously it's a whole lot better.
So, whether you're treated surgically, endovascularly, whatever, and again, Dr. Weiss alluded to this, optimal medical management is critically important. So you need to not smoke, you need to watch your blood pressure, you need to, eat right, you need to exercise. And in fact, those are the pinnacles that everybody should get, whether they get an operation or whether they get a stent. Now, stents work very well and they improve blood flow. They're not perfect. They have a tendency to re-narrow. Why they re-narrow in some people more than others? Clearly, if you continue to smoke, they'll re-narrow faster. So that's one of the caveats. But exercise is probably the most important thing. If you walk and exercise regularly, number one, it'll help keep it open. Number two, if it begins to narrow, you'll identify it right away because it's much easier to fix these when they're partially blocked than when they're completely blocked. Once they're completely blocked, it's much more difficult to fix.
Boy, when you say the word exercise to me, you're talking to me right in the center. So I think that's so important. I thought we mentioned earlier somewhere, maybe it was before the camera was on, about sleep apnea. Dustin, do you think that that's a big factor here?
I'm not so certain with arterial disease, but with lower extremity edema, sleep apnea that's untreated, you do increase your right heart pressure, and so they'll manifest as bilateral extremity edema. So we do see patients with leg swelling that don't have venous disease, and that's just something that they need to see their primary doctor for and manage to see if that does improve their leg swelling.
I think sleep apnea is a big.
And what I would interject is that it's now recognized, certainly in the cardiac arena, not so much in peripheral vascular disease, but in cardiac arena, that sleep apnea is a contributor because it reduces your oxygen saturations at night, it puts a strain on your heart, it clearly contributes to cardiac morbidity. And so,
death.
There's no question that and that's been kind of a renaissance, that we've recognized that we need to screen more, and obesity is a problem in many of those patients, that with weight loss, which is difficult.
Really difficult.
But often that will help. But again, it's only now that we're beginning to recognize that we need to test more patients for sleep apnea.
Atrial fib, also that abnormal rhythm and atrial fib. Please discuss how to treat swollen, weeping legs. If the fluids from the legs has a strong, bad smell and weeps in puddles, is it likely infected? Are others at risk if they come in contact with leg fluid? What would you do with someone that serious of a venous problem?
I think the first thing is compression, and if you have open sores, compression stockings are great, but if you have open sores, then they definitely need to see their primary doctor and probably a vascular specialist. Wrapping the legs, we'll do leg wraps, and that will often get those to heal. And then they need to look into the cause. If they have venous disease, that definitely needs to be treated. If there's other patients that have problems with lymphatics we talked about, and there are some treatments for that, mainly the compression, but then you can also get some pumps that help relieve the fluid.
Sometimes when you get the fluid out, though, as you're getting the fluid out, it hurts. So they avoid that treatment.
Yeah. And they do massage too, they get the fluid out, but getting the fluid out is important because that's they won't heal the cracks in their skin or the sores as long as they have the swelling. As far as is the fluid threatening to other people, no. Is it infected? It's hard to tell. Getting the edema out is important because if you have leg swelling, you are at increased risk of cellulitis or infection of the skin and the fluid. And if you get cellulitis or infection of the skin and fluid, then that just makes the factors worse and worse, and so it's kind of a vicious cycle. So I think it's something that patient definitely should seek some medical care.
Yeah. And my experience in what you've described is a patient who's largely non-ambulatory and spending a great deal of time with their leg dependent.
Yes.
And so
get it up.
Frequently because of spinal stenosis or they have back problems or orthopedic issues, they tend to sleep in a recliner rather than in bed. If they can get their legs up so they're elevated to at least the level of their heart, that often will help. This is one of those chronic situations. When it gets that bad, my sense is that this is someone who's spent a great deal of time with their legs down, and gravity is not their friend.
No. And if you, time and time again, when I'm getting results, I'm finally diuresing them with, maybe I'm adding a little diuretic. I do it reluctantly, but I do it. And you elevate those legs, and then you get the ACE wraps. They're pained by it. So, oftentimes I'd hospitalize them, cover them with pain medicines, force the edema out with the wraps or whatever, and elevation until they're there and the pain is reduced, and we can move forward to getting back to exercise. We have a roll-in. The value of having a primary care physician cannot be overstated. But you also have to go and see them regularly, even if you don't think anything is wrong.
Well, I went into my primary care doctor and she listened to the arteries and she said something didn't sound right. And so then she sent me to Dr. Weiss in Sioux Falls at the Heart Hospital, and that's when they said it was 70 to 99% blocked. That was the first I knew anything about it. Feel fine. Feel like I did before I had it done. So, it wasn't bothering me at all. It's just that the primary doctor, Katie Jones, found it and then went from there. It probably could have developed into something if we hadn't caught it early enough. Right here is the incision from your ear down to your neck. And then here they cut it open and scrape out all the plaque that was built up in it and bypass the blood flow and sew her back up. It's amazing what they can do. 3 weeks, something like that, because I usually go up to cardiac rehab, and within a week or so I was back up to cardiac rehab, doing it easy, but I'm still back up there doing the exercises and stuff like that. Keep going to your primary doctor, they're the ones that find it. And, I never had no idea that I even had it, I was never short of breath or anything like that, so, I never had any symptoms.
Well, we really appreciate Roger's primary care provider, very good clinician. Any comments about what Roger was saying?
I think, a physical exam is important for vascular disease. We listen to the carotid arteries and you can hear a carotid. It sounds like he had a he did have a carotid bruit, and that led to finding the stenosis. And like I said earlier, I think if it's over 80%, your risk of stroke is significantly decreased by either a carotid endarterectomy like he had or a carotid stent.
Yeah. A caller from Rock Valley, Iowa has a calcium buildup in the veins in her legs. The doctor has been removing the calcium about every 2 weeks. Is there anything I can do to stop this buildup? I don't understand. Do you have any idea about what kind of calcium reduction this person is getting, Mike?
I don't, and I'd need, very honestly, I'd need a little bit more information. There have been some techniques called chelation that was to reduce arterial calcification in the arteries, not in the veins typically. It was not particularly effective, and it's really kind of fallen by the wayside because it really didn't accomplish what it had hoped.
It would suck the calcium out of the blood vessels. The blood vessels would go to the bones, readily grab all of the very easy access in the bones, not the arteries, and it just didn't work.
Right. So I'm not sure. I wish I could answer that, but I without a little bit more information, I'm sorry I can't.
I don't have a good answer. A caller from Cowridge, Nebraska states that after a few vascular surgeries on her legs, why am I fine walking around and sitting but feel lots of leg pain shortly after laying down? Maybe that's when the edema really does reduce and she can feel the pain.
I guess it could be. Or it could be that her blood vessel disease. You would expect her to have pain while she's walking.
Yeah.
especially if you're having pain arrest. So, I mean, it could be that she's more active and she could have, some joint problems, some orthopedic problem as well as vascular disease.
There's something else happening.
Yeah, so I think it's important for patients to remember and for our audience to recognize that vascular disease, when it involves the legs, presents itself as discomfort or distress with walking, with exercise typically, except for what Dr. Weiss had previously described where you have rest pain. But for the vast majority of patients with claudication, you have to walk to bring the discomfort on. Now, there's lots of reasons for people who have leg discomfort. There's peripheral neuropathy, there's spinal stenosis, there's orthopedic issues with degenerative joint disease at the hip or knee or other places. So, and some of it's just muscular. So typically pain at rest is not usually claudication.
Right.
Okay, so, and the other thing is it's not variable. It tends to be the same each time. So someone will say, every time I walk a block, I get this discomfort. If I stop and rest, it goes away. Those are kind of the key components that we ask patients about that help us make that determination.
Right. A man from Rapid City asks, what are your thoughts on using Daflon for swelling in legs? Daflon. It's very effective for me. So I've never heard of Daflon for swelling in the legs. Maybe it's Teflon, or is it a particular type of?
I don't know. I guess I'm not sure if it's some type of wrap.
An elastic wrap
or if it's something that's taken. But I would think, pretty much for leg swelling, what it's important to do is have, compression to help push that out. And we have compression stockings that are tighter at the bottom than the top to help
push
promote that. Yeah.
And I like to start with like 15 to 20 pound, then go to 20 to 25, and then max out at going to 30. But certainly you're safe at 20. The problem is if you get too tight and there's arterial disease, then you can compromise the arterial flow. Do you see that happen?
No, not usually, because most of the time the blood pressure is high enough that even with 30 or 40 millimeters of compression, you're not. Now there's a few circumstances where it can occur where you have really reduced blood flow, but for the vast majority of people, the blood flow is, even in someone who has claudication, still may have an 80 or 100 millimeter of mercury pressure below the knee. Mm-hmm. So you're not going to compress that enough to
compromise arterial flow.
Right.
Most of the time in my whole career, I went for 20-pound support hose, and I went below the knee because they'll actually wear those, and put them on in the morning, take them off at night.
Right. The critical issue is they don't do you any good if they sit in the dresser drawer. Yeah. So you have to wear them, and if they're too tight, people won't put them on, and if they won't wear them, then obviously they're not doing any good. So I think you're absolutely right.
Yeah, and the majority of patients' symptoms are below the knee as well.
Right.
And then if they can't wear compression stockings, there are some other devices that you put on that are Velcro. So you can put them on with it's not as tight, and then you can strap the Velcro to tighten it. And often a lot of patients that have some swelling, it'll be difficult for them to get down there and put the socks on. So there are some other options. So compression, whichever type of device you're using is the key.
Yeah,
I've run into those Velcro.
People with arthritic symptoms of their hands where they just can't pull those stockings on. There are some devices that will help, but also the Velcro devices have been quite helpful.
Here's a question about an AVM. Can it be detected with a screen? What is an AVM, Mike?
That's an arterial venous malformation, and those are
in the brain often?
Well, they can occur in the brain. They actually can occur almost anywhere. And interestingly, they often are brought. They're there, but they're sort of quiescent, and then it takes a little bit of trauma to bring them out, and then all of a sudden they flourish and you find them. They would not be routinely found on screening. Now, if you had a special, scans of the brain for some reason, then an AVM in the brain would be found. That does put patients at high risk for a bleeding event, an intracranial bleeding event for that type. For those that are peripheral AVMs, they will become evident if they enlarge, and your primary care person may notice that there's a bulge, or they can listen with a stethoscope over that area, and they'll find that a high-pitched sort of sound that's continuous, sort of a machinery-like murmur. So,
is it necessary to fix them?
Small ones can be often left alone. Larger ones, if they cause pain, if they're problematic, There are techniques, some of them can be embolized, so you don't have to have an operation. But unfortunately, they're not a real frequent problem.
Okay. I got a good one for you. Sleep apnea causes glaucoma?
I'm aware,
Okay, we'll skip
but
that.
I'm not an ophthalmologist.
No,
so I
you
don't know.
said that earlier to the students.
So.
A male caller from Sioux Falls asks, what is the difference between Planet Health screenings at Avera versus the traveling screenings mentioned earlier? That's a good question.
Well, I think in general, most of the screening studies will include your carotid ultrasound, blood pressure study for your legs, and ABI. They'll check an aneurysm, and then they'll do sometimes a bone scan, or a calcium score of the heart. Now, as far as the differences, I'm not sure what obviously it depends on the traveling ones. If you're in a small town and that's available, then that's the same. But I think that I'm not sure
Maybe
what the cost would be. But I think that as long as I think they probably both have the same general screening. Don't you think?
Yeah, except for the calcium score. That would be the one thing that Planet Heart would have, where you could look at the calcium of the coronary arteries, which requires a specialized CT scan, which is not available at most of the traveling type programs.
But how good of a test is that?
Well, there is a certain group of patients in which it's quite helpful. Those who are unaware that they have coronary disease and perhaps fit into that mid-age group, say 45 to 65, where they're, that kind of thing. Once you get to be more elderly, beyond 65,
you're going to have
you're going to have calcium score, right? And the real young patients probably not going to have any calcium. So it's really that middle group. And if it gets them to look after themselves, if it gets them to quit smoking, if it gets them to exercise, then it's a benefit.
Yeah.
The Planet Heart screening is very cost effective, and I can't tell you the exact cost. I would guess that the Planet Heart screening is probably a little bit cheaper, but I don't know that for a fact.
Okay. All right. A male caller from Sioux Falls asks, what exactly is a stroke? Dustin?
Well, a stroke is when you have, it's similar, like a heart attack, your heart's damaged because you interrupt the blood flow there. A stroke is the same type of process, but to the brain. There's different causes, but a stroke in general is any time that you have blockage of the blood flow to the brain causing damage to that tissue.
All right.
And it could,
go ahead.
It can either be, a stroke, which is a significant defect, either you can't move your arm, leg, slurred speech, can't see out of an eye, or a significant neurologic thing, or it can be a TIA where you may have a neurologic deficit, but it lasts only a few minutes. Both of them are things that need to be, you need to see a medical, go to the emergency department and see a medical doctor or a medical care provider as soon as possible, because those are both things that can be ignored. Because even if your symptoms get better right away, that could be you're going to be higher risk of having another stroke, and so they're important to be evaluated. They can be caused by carotid disease. They can also be, there's other factors. It can be from a
or the clot can occur just right in the brain,
or it can be from the heart, or
But if it's a clot that flips from the heart or from the carotids, those are important to discover. So you need to get in.
Yeah, I think yes.
Right. So you have to separate. I think. Remember that some strokes are hemorrhagic strokes, meaning you've had a bleed, and that's a separate category. So half of them are kind of related to bleeding events, all right? And then the others are, you have as you said, cardioembolic. So if you have atrial fibrillation, you need to be evaluated and put on blood thinner or put into a normal rhythm. Yeah. If you have blockage in the neck blood vessels, you need to have that evaluated to determine whether that needs to be fixed. If you have high blood pressure, your risk of stroke is 7-fold increased if your blood pressure is not adequately controlled. So that one of the things that we often sort of neglect is the patient who doesn't get their blood pressure checked very often, or doesn't like taking the medicines. So there are medical things that can be done too that are very important at helping to prevent stroke.
And following the doctor's orders, or the direction, or choosing to do what the doctor recommends is a good idea. A female from Sioux Falls asked, can you talk about smoking and chewing tobacco? Is chewing tobacco as serious as smoking? Female from Rapid City asked, that was it. Chewing versus smoking, and then throw in vaping.
Well, I would comment just real briefly. I think certainly tobacco use in general is bad, okay? The characteristics and the types of disease process are a little bit different. Clearly cigarettes have been associated with originally lung cancer, and then in the 70s we recognized a major contribution to coronary disease and peripheral vascular disease, because all of those bad humors that they take in the smoke are basically coating the inside of your blood vessels. Chewing tobacco tends to, lip and tongue
Throat
cancers
cancers, yeah.
are problematic. There also is increased risk potentially in bladder cancer and some of the other things but it's a little bit different in the sense that they don't contribute to the same extent to obstructive lung disease, COPD, or emphysema.
All right.
So,
very good answer to hard question. I have 3 varicose vein surgeries over the last 20 years. I broke my ankle last year, and my leg swelled up so bad it broke open my stitches. The nurses thought it was because so many veins were destroyed from the surgeries that the blood wasn't circulating as well. Do you think this is true?
Probably not.
It's not the varicose vein surgery that brought this on.
So usually, the varicose veins, that when we strip varicose veins, or even if we take out the saphenous vein, those are your superficial veins, and the veins that you really count on to decrease your edema and problems like that after surgery
are inside.
Is the deep veins. So and those aren't veins that we will
surgically
take. So when you have a heart bypass, we usually use your superficial vein, and that's generally well tolerated, or even a peripheral bypass will use it. So I don't think that contributed. Now, what would concern me if you have surgery and you have a lot of swelling, you are at increased risk of having a blood clot in your veins after surgery, though.
All right, and that could be significant. Please stay tuned after this short break. We'll have important takeaway messages from our guests, as well as answer to tonight's Prairie Doc quiz question.
It was too easy for Europeans to dismiss the traditions of the American Indians, and it was to our loss. The Lakota, Dakota, and Nakota Nation, history and health. Next time on Call with the Prairie Doc.
All of us want our family, neighbors, and friends to have the ability to make appropriate decisions about their health care. To do so, they need access to information from reliable sources like Dr. Holm and his guest physicians. Hello, I'm Stephanie Herseth-Sandlin, and I serve on the volunteer board of directors of the Healing Words Foundation, a 501c3 organization established to support the work of the Prairie Docs. With your charitable donation, you can help the foundation continue to offer free and easy access to the entire library of Prairie Doc health education programs. This mission is so very important to rural communities and residents in particular across South Dakota and neighboring states. Please consider a personal or corporate gift. Just go to prairiedoc.org to find more information on how you can help. Thank you.
What is your thought about 15 seconds, bottom line people need to take home?
I think for peripheral artery disease, an important thing to do is lifestyle modifications. So quit smoking, get up and walk, make sure you see your primary care doctor like we talked about earlier to make sure that you're being treated with aspirin and medically managed appropriately.
Right. Mike?
and if you have problems, you shouldn't be afraid to see a practitioner. There are many things that can be done. It doesn't mean that you're going to have an operation. Many things that can be done less invasively nowadays. And we often still use medications and exercise programs, so there are many things that can be done. So don't avoid coming to the doctor if you know you have a problem.
All right, wonderful points. And now for the winner of tonight's Prairie Doc quiz question. It's a reverse multiple choice this week. Pick the least important key to longevity and preventing vascular disease. 1, eating a healthy, balanced diet, low-calorie diet. 2, exercising and avoidance of sitting for long periods of time. 3, controlling diabetes. 4, keeping cholesterol in check. 5, avoiding smoking. And the answer is, all the options are important, but the least powerful is number 4, keeping cholesterol in check. Agree, gentlemen? It's a tough issue, of course, cardiologists. And it was Mary from Sioux Falls who answered the question correctly. Thank you, Mary, for participating, and a book will be in the mail to you soon. We'll be right back after this.
For nearly 2 decades, the Prairie Doc organization has endeavored to enhance health and diminish suffering by providing useful information based on honest science in a respectful and compassionate manner. Health professionals volunteer to answer your questions each week, creating a vast Prairie Doc library of medical information available to you and your family 24 hours a day. Make sure you don't miss a thing. Follow the Prairie Doc on Facebook and YouTube for free and easy access to the entire Prairie Doc library.
For years, I cared for a young gentleman with recurrent leg swelling associated with redness, fever, pain, and open sores between his toes and on lower legs, and the rash of athlete's foot. Once again, the emergency room doctor admitted the patient and started him on intravenous antibiotics, while the nurses put on support hose and encouraged him to elevate his legs. There are 2 types of blood vessels making up the vascular system. Going away from the heart, blood is pumped through arteries, providing oxygen and nutrients to almost every cell in the body. Coming back to the heart, blood is returned through veins, oxygen depleted and loaded with waste. When venous blood passes through kidneys, liver, and lungs, waste is removed. When artery flow is blocked, pain, loss of muscle strength, and open sores develop. In contrast, when venous flow is blocked, swelling and congestion occur, which can also reduce arterial flow. Most dangerous, poor venous flow can result in blood clots. A list of reversible causes for arterial blockage includes regularly eating too many calories, not getting enough exercise, smoking and failing to connect enough with people and nature, which is entirely underrated. Others may talk about pills and supplements, but the plain truth is that nothing comes close to these healthy lifestyle habits in preventing premature obstruction of arteries. A list of preventable or treatable causes for vein and venous obstruction with swelling in the legs is long. It includes congestive heart failure, inherited varicose veins, jobs that require prolonged sitting or standing in one place, and leg trauma, all of which injure vein valves, making edema worse and increase the risks of clots. Clots developing in veins are dangerous. They can move to the lungs, threaten life, and worsen swelling. My young patient had a combination of foot fungus, or athlete's foot, and bacterial infection growing in toe cracks and leg sores. He also had venous insufficiency. The valves in the veins were destroyed, and new blood clots, possibly triggered by the fungal and bacterial infections. His condition was complicated indeed. We elevated his feet even higher, increased the pressure of his support hose, and added medicines including a low-dose diuretic, an anti-fungus medication, and an anticoagulant. His leg swelling resolved and stayed that way, especially because he wore 20-pound below-the-knee compression hose. The vascular system makes up an incredibly complex organ system. Please take measures to protect blood vessels by understanding the values of a healthy lifestyle and, when needed, wearing firm below-the-knee support hose. A big thank you to our guests, Mike and Dustin, for volunteering to come to our studio in Yeager Hall on the campus of South Dakota State University and add their experience and knowledge to our discussion tonight. Thank you.
Thanks very much.
If you would like more information about this program or to see more episodes, please like and follow us on Facebook or visit us at prairiedoc.org. Well, that does it for tonight from all of us here at On Call with the Prairie Doc. Until next time, stay healthy out there, people.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call with the Prairie Doc on South Dakota Public Broadcasting. Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota.
and with ongoing support of these individuals and institutions.
Brookings Health System,
Ophthalmology Limited,
Avera Heart Hospital,
Dakota Allergy and Asthma,
Fishback Financial Corporation,
Vance Thompson Vision,
Urology Specialists,
Brown Clinic,
American Academy of Family Physicians Foundation and South Dakota Academy of Family Physicians,
Black Hills Medical Society,
Aberdeen District Medical Society,
Brookings Madison District Medical Society,
Sioux Falls District Medical Society,
Dakota Bank,
Orthopedic Institute,
Physicians Care Sanford Clinic Community Service Committee,
Aberdeen Asthma and Allergy,
and Swiftel Communications.